Our conversation on shaping the future of healthcare for a healthier world features Dr. David Feinberg, head of Google Health, and Dr. Mark McClellan, who is both a business professor and director of the Duke Robert J. Margolis Center for Health Policy at Duke University. They are interviewed by Dr. Stephen Klasko, CEO of Jefferson Health.
I am thrilled to be here today. And I think one of the things that really makes this conference special is bringing stakeholders from all sorts of different industries together. And also that we don't mind asking the really tough and bold questions. And I think we've achieved both of those with this panel, with Dr. Mark McClellan and Dr. David Feinberg, bringing health policy, big tech, but all of us share the view that disruption needs to happen in a positive way. So I'm going to start with the most difficult question first, so the rest will be easy. So Mark, despite the ACA, CMS changes, some of which you've been responsible for, and David, despite the incredible amount of capital that's being invested in digital transformation, of which, David, you're working on very well with Google, so much of which, whether it be telehealth or online education, was not available to 20% of Philadelphians in my area who didn't have broadband. How do we move health policy, and those of you responsible for the fourth industrial revolution, to create an environment of, let's call it, universal connectivity, and be sure that we're not creating a new generation of virtually or technologically homeless group of underserved patients? How do we ensure that your zip code is not the most important component of healthcare outcomes? An easy question to start, and either one of you can go ahead.
Well, first of all, it's great to be here and to be with both of you. Let me push back, Steve. I think actually your zip code is the most important determinant of your health. So what's happening in your community is as important as your genetic code. And so access to food, understanding where housing is, understanding medical information in a way that makes sense to you is super important. So for us, it really is about organizing the world's information and making it useful and accessible. So when we think about things like COVID, for example, which I'm sure we'll get into, we have had 400 billion views of our COVID information page on YouTube. So that reaches wide audiences. The other thing that you mentioned around broadband, there's really the next billion users we think that are coming onto a mobile platform where smartphones will become much more common than they already are. And as those folks come on, what can we do to make sure that they can get the right information on their phones in a way that's mobile, that does what you're asking in your question and help equalize ability to access care, high quality care, and affordable care?
Just to pick up on David's comments, first of all, I too am really glad to be part of this unique dialogue. And zip code is a proxy for things that really matter for health, what your living conditions are like, what the risk factors in your environment are like, whether there's an easy place for you to exercise, and access to healthcare is a piece of that. Hopefully with the more detailed data and capabilities that are coming to act on that data for individuals, we'll be able to translate what looks like a hard thing to really transform a zip code into something completely different, into ways to make progress on that. There is increased attention driven by digital capabilities to be able to reach people where they are in their homes, as we saw happen during the pandemic, and to connect them to a broader range of resources to help improve their health. Not just scheduling a visit with a doctor, but figuring out if they're feeling isolated and mood issues or behavioral health needs could be met, figuring out if there are other social service needs, food insecurity, housing insecurity, and helping to connect that. Unfortunately, as you say, we don't have as much data connectivity as we'd like to support that. And I think one of the most important changes in healthcare that can help make that happen is to set up our payments or other policies in a way that reinforce caring for the individual where they are at home, and not just paying for services that are often downstream and not really going to get at those core issues that are embodied in your zip code.
Mark, let me follow up on that because one of my mentors, Bill Kissick, when I was at Wharton, wrote a book called Medicine's Dilemmas, Infinite Needs, Finite Resources. Sound familiar? That was about 40 years ago. And he talked about the iron triangle of access, quality, and cost. And he said, if you increase one item, you get an increase and decrease another. If anybody says you're going to increase access, increase quality, and decrease cost, it's not going to be disruptive and painful and not telling the truth. So if you think about the ACA, there was a lot of, oh, good news. We're going to increase access, increase quality, decrease cost. It won't be painful. I think in our country, President Trump said, it's going to be terrific, fantastic, unbelievable, and huge. And it really wasn't any of those things. So how do we make sure that we're not just giving more people access? What can government do? Not just giving more people access to a broken, fragmented, expensive, and inequitable system and hoping we'll transform. So you ran the CMS. What are the biggest obstacles to achieve that brass ring of sort of wider adoptions of all the things you're talking about, efficiencies and value-based care?
Well, one thing that is special in our time, as opposed to that, you're right, that iron triangle of cost, quality, and access has been around for a while. But one thing that we've seen consistently happen over the last 40 years, Democratic, Republican administrations, actually in the US and elsewhere around the world, is increased spending. And for a long time, for basically 1970, 1980 through the 2010 period, that was associated with improvements in outcomes, not just for wealthy individuals, but for lower income populations, Black and brown Americans, minority populations here and elsewhere in the world. That had started to change before the pandemic, where we're seeing a leveling off of improvements in cardiovascular mortality, an increase in so-called deaths of despair from substance abuse, violence, and suicide. And as a result, even before the pandemic, life expectancy in the US was falling. And with the pandemic, with a disproportionate impact on Black and brown Americans, we've seen a loss of the gains in life expectancy the last 2 decades for Black Americans, for example, and decreases in life expectancy overall. So we have more clear evidence now than ever before that it's not just a matter of putting more into healthcare that makes a difference. We need to put more into healthcare, like we were just talking about a minute ago, that meets people where they are, that uses digital technologies and other innovations like care teams and things that you're doing at Jefferson, Steve, to change the way that care is delivered. If we don't do that, if we don't sort of broaden the lens for care delivery to support digital health and these other innovations, I don't see those trends turning around.
Thanks, David. We've been friends and colleagues for a long time. You moved from the traditional healthcare ecosystem, doing a great job both in California and Pennsylvania. And now you're leading Google Health, and Google's transformed so much of our life. We spend almost $4 trillion a year in healthcare, most of it, as Mark said, for treating diseases and sick care, not necessarily preventing them. So and you mentioned before a lot about data, all the data you're aggregating. I've often said we don't have a problem with not having enough data. It's just we have a problem with what we do with that data. So how do you see AI and machine learning transitioning us to healthcare that's truly predictive, preventive, and outcome-based, which is what Mark talks about all the time in health policy?
Yeah, so let me give a couple examples, one kind of in the inpatient setting and one more from a community standpoint. So from the inpatient setting, our team in London came up with an app, really, really simple. So the rapid response team, the team in the hospital, gets called when a patient's starting to go into kidney failure. And the only thing the app did was tell you if creatinine went up, which is a measure of kidney function. Okay, that's it. Creatinine goes up. We saw a 30% less folks had cardiac arrest. Cost of care went down 14%, and time to diagnosis, 17%, and time to diagnosis goes from 4 hours to 14 minutes. Okay, so that's great. Then we say, well, instead of looking creatinine, let's do AI. So partnership with the VA, we look at 600,000 variables per patient in real time through their EHR. Now time to diagnosis goes from not 4 hours to 14 minutes, but -2 days. So 48 hours before anything happens clinically, we can tell you with 90% accuracy, this patient who has no clinical signs is going to be on dialysis. Like, it's fundamentally changing the sense of anticipatory medicine. So that's predictive. We can do the same with mammography. We can do the same when we look in the backs of folks' eyes for diabetic retinopathy. Not only can we reach specialty level performance, there's novel signals in there that none of us learned in med school. We can tell your hemoglobin A1C. We can tell your age by looking in the back of your eye. So that's in the medical side. But when we start talking on the consumer side or on the clinical side, folks come to Google when they have a new diagnosis, when they have a question, when they're trying to find where a vaccine is. We launched 5 self-assessment screeners, clinically validated tools that people can do themselves to see where they are. So examples are anxiety, PTSD, post-traumatic stress disorder, postpartum depression, COVID screener. The average person waits 9 years when they have an anxiety disorder like OCD before they share their symptoms with anybody, their primary care doctor, their spouse. I'm washing my hands so they bleed, but I have so much shame around it, I'm not going to tell anyone. Okay, now they can take a self-assessment, completely anonymous, on Google, see where they are, and then we can tee them up with teletherapy. We can help them find an FQHC. We can help them look at their insurance and see where they can get care, get an app, whatever it is. If we can take that 9 years down to 9 minutes or 9 seconds, we think that that platform that we have can really close the gap of people that are suffering to people getting into care. And we all know when you can get to the right level of care quickly, it decreases problems downstream, right? So if you can get easy access to primary care, or if you can get right into the urgent care, or you can do self-care, we know we avoid a lot of the trouble that comes when you make people wait, and then boom, in the night, something goes bad and they show up in the ER and our terrible system of do a lot starts.
So let's take that to the next step. Obviously, EMRs have been a big advance. Those are critical of the traditional EMRs, would say it's the first progress in technology in our history where you need more humans just to get back to where you were. We're hiring scribes just to get back to the doctor-patient relationship. How do you see Google working with traditional EMRs to improve these healthcare outcomes? And how do you see Google helping to potentiate and be part of that whole predictive analysis of data and interoperability sphere that we're clearly going to need, and something that Mark talks a lot about?
Hey, at Google, we're good at organizing information, right? That's a key thing that Google's good at. So we want to bring that technology into healthcare. So in partnership with Ascension, and we have other partners lined up, what we've done is say, look, the patient you're seeing has 3 or 4 electronic health records that are taken care of. They might be using something in the outpatient setting. They could be 1 or 2 different systems in the inpatient setting. We will normalize that information for you. And then we will present it to the doctor, the nurse, the clinician in a way that's totally intuitive. A Google search bar. So you get called in the middle of the night because you're the hospitalist on call, the patient has GI bleeding. You type into a Google search bar, anemia, melena, you can misspell it. And within a second, all of the information on that individual patient is now presented to you in a way that allows you to take care of them. Are they on any protein pump inhibitors? Are they, what are their normal hemoglobin levels? What are their vital signs? And then help you write the note, help you make sense of it. What we're measuring is, can we get doctors and nurses to spend more time with the patient than at the computer? And right now, all of us have had this experience where you go into the doctor and they say, what was the results of that test? And you know it's at the computer, and you look at them with disbelief. Well, one of the docs at Ascension said to us, I'll build a statue for you if you can find this person's CPAP, a measure of sleep apnea. And we said, well, just type in CPAP, and boom, it comes up from an OCR that was sent in from a fax. So we can take that information on an individual patient and allow that doctor or that nurse to find it in seconds. And that same normalization of data allows us to make predictions on populations, allows us to make predictions about who's going to be readmitted. The EHRs are fantastic because they digitize the record. Now what we need to do is put a layer on top of it that actually makes that useful. And it's useful for an individual, and we got to work on doctors' workflow. And it's also useful when you're managing larger populations.
All right, so Mark, David's got me really excited now that my dream of healthcare at any address, getting care out to where people are going to be potentiated by Google. But on the other hand, I think many years ago, Upton Sinclair said it's hard to get somebody to do something when their salary depends upon them not doing it. So what could an administration with courage do to start to align the payment models with value and outcomes in a way that would make both you and David happy?
Well, I do think the payment models matter. I want to get to that in a second. I also want to pick up on David's point about just how powerful getting the right data paired with the right AI tools can be for improving care. I do want to have a cautionary note there. So lots of data in EMRs. Most of it was designed, to your point, to support billing and delivering particular services when doctors are paid on the basis of delivering more services. So writing down all that detail is intended not just to help, and maybe not even namely to help the patient, but it's designed and organized to support payment. And great that we've got Google tools now that help make it actually useful for integrating data at the person level. There are some cautions there too. If you're not measuring the right data, you can make some big mistakes. There's a good study done last year and the year before by Ziad Obermeyer and some of his colleagues at Berkeley, which basically found that AI intended to help the most severely ill patients was actually aggravating racial disparities because the measure of severity that they were using was intensity of medical care use. So hospital visits, hospital spending, and that turned out to be more correlated with race and barriers to, structural barriers to access for African Americans than it was with actual health status. So you got to measure the right thing. And while EMRs historically have been good for care within the hospital, they often don't include basic information like what are your living conditions at home? Do you have a safe environment? What zip code are you in? Things like that could really add value. So we got to focus on the data too. And to make all this run, exactly as you said, you'd like to have policies that make the right thing to do, the easy thing to do. So some of those policies include things like data interoperability rules so that people can have confidence that their data coming from different places that can be put together to get them the best care. It's going to be handled securely, and it's going to be handled in a way that's consistent with their wishes, and it's going to be handled reliably. But most important is probably the payment rules and shifting payments so that if what we really want is a usual source of care, a clinician or a team that's trusted by the patient and can help them make the most sense of putting together all of these different apps and tools that are out there that enable them to get more activated in making decisions about their care, more confident, more comfortable in dealing with issues like you said before, or like you all said before about some of the behavioral mental health issues, getting right connected to a telehealth service to assist them with that. That's not going to happen if we keep only paying for the complications and only paying for the stuff that happens in the hospital. So lots of promising work, and we've seen these models work during the pandemic for primary care groups or integrated care systems that are paid more on the person level, doing a much better job when fee-for-service revenues fell during the shelter in place, and when new models of care needed to be adopted that relied much more on telehealth, that supported things like getting a COVID test into a patient's home, getting that patient referred for therapy quickly if they became ill. None of that's well supported under fee-for-service. And so hopefully we've got a good tailwind coming out of the pandemic in the US and elsewhere to really move to payment models that support that kind of integrated person-focused care that David's tools can really help enable.
So let me take that. I mean, what I'm hearing a lot of is need for partnership. And in the book that Hemant Taneja and I wrote on healthcare, a manifesto for health assurance, we posited about what would happen if a Silicon Valley entrepreneur and the CEO of a 196-year-old academic medical system walked into a bar, got married, and had a kid. How would Google and a place like Jefferson or Duke, what would that kid look like where we're actually working together as opposed to just buying apps? David?
So I think we've had that kid. I've been at Google now 2+ years, and I don't come with a strong tech background, right? I come from the same background that you have, Steve, of running large health systems. After being here for 2 years, I am positive that our technology can save lives. It's mind-blowing. I'm also equally positive that if we don't get two things right, the technology will never make it to the light of day. And those two things are people have to trust us, right? We have to establish trust. And the best way for us to get that trust is through partnerships. So this isn't Google taking care of you. This is Google on an information page saying in the UK, this is what the NHS says, or in the US, this is what Mayo Clinic says, or your Ascension doctor saying to you, this tool is allowing me to take better care of you, or in our partnership with Mayo on radiotherapy for cancer patients. That's the Mayo doctor using our tool. We are not, if we're getting married, you and I, Steve, we are not the caregiver. We need to provide tools to those frontline people so they all have capes on.
Well, this is great. And I couldn't agree more that trust is more important than technology in some way. So I just want to end with this. I like to quote Jason Kidd when he went to the Dallas Mavericks, said, I'm going to turn this team around 360 degrees. We've done a lot of turning things around 360 degrees in healthcare, but just listening to you and watching what both Google have done, what you've done at Duke and CMS, I am really confident that post-COVID, we're not going to be using that quote 4 or 5 years from now. I can't thank you guys enough for being part of this amazing Vatican conference, and we'll look forward to hopefully next year at the Vatican.
Thank you.